Hi guys. I feel like this Zoom angle is really not ideal, but we'll deal with it. So yeah, my name is Lucia. I'm a junior doctor and co-founder of Leap. And today I'm going to talk about kind of my career path so far, kind of what led me to where I am now. And then I'll talk about what I'm doing now, which is working on lead exposure and running Leap. And then I'll also kind of go into a bit of like what it actually means to be running a health policy nonprofit, what the day-to-day looks like, and that sort of thing. Just for context, are most of you undergrad medics? Anyone clinical yet? A couple people. Okay, cool. A few people. Nice. And then we can answer questions, and I'll be hanging around for pizza and stuff, so we can chat afterwards as well. Can everyone hear me all right? Does that sound good? Okay, nice. So like most people, I think, who decide to go into medicine, I was mainly motivated thinking, oh, I want to, improve the world. I want to improve people's health, that sort of thing. I think I initially thought that I would probably specialize in something like infectious diseases, maybe public health, and then maybe go on to work for some kind of organization like Doctors Without Borders or the WHO. So a lot of people now that I'm doing something that doesn't involve that much clinical medicine will ask me like, oh, do you regret studying medicine? Was it useful? Like, was it a good choice? And basically, I don't regret it at all. I think it gives a super helpful and relevant background and massively cross-applicable skills. I think studying medicine basically teaches you kind of practically applied science. Like how to do research, how to interpret evidence, basic statistics, evidence-based decision-making, and it also teaches you communication skills, how to interact with people, how to get stuff done. And those are basically the two things that you need to run a like high-impact health policy nonprofit, or probably loads of other kind of high-impact careers. It also gives you a huge amount of credibility, like possibly wrongly or rightly or wrongly, like once you graduate and you're a doctor, people will just automatically assume that you're quite competent and trustworthy. And that's really advantageous in a huge variety of careers, and definitely advantageous in the type of advocacy work I'm doing now. But I've also found that it has some downsides. I think one of the major ones for me is that once you start the kind of path of medical school, being a junior doctor, it's very hard to see alternative options other than the kind of typical like clinical practice path that you see around you. And so it can be quite hard to motivate yourself or realize what other kind of options there are to do alongside medicine, or potentially like higher impact options. So one of the things I found really helpful kind of along my career path was getting involved in effective altruism in Cambridge. Effective altruism is basically kind of like a social philosophical movement about trying to figure out the most effective ways you can improve the world. So there was no high med at the time, otherwise I definitely would have been involved in high med. But I got involved in effective altruism at uni, which was really helpful. I basically, hello, it's all good. It's basically was just a really great opportunity to like learn from other people who care about the same things with slightly different perspectives. Like, how can we have an impact in the world? It's also really motivating to be around other people who have those same ideas, and helped me stay on track with like why I decided to study medicine in the first place, which is because I want to have an impact in the world and not get distracted by this very kind of straightforward career path in front of me. And just kind of like blindly follow that, but kind of help me keep thinking about like what is the best thing I could be doing at any given moment. It was also really good at opening up opportunities to get involved in cool research projects, cool nonprofits that I volunteered with. And then running a society at university is also just is basically like small scale nonprofit entrepreneurship. Like you learn how to organize stuff, manage things, and that was pretty useful. In fact, the person in the middle of that picture is now co-director of Leap. We hired her just a few months ago, and this was taken 7 years ago. So also helps you hire people in the future, apparently. Yeah, so that was cool. And then the next thing I did after graduating was I worked as a junior doctor for 2 years in London. So I completed the foundation program. And my thinking with that, I already knew at that point that I didn't want to do pure clinical medicine for the rest of my career. But I thought completing the foundation program would keep my options open for a bit longer. After F2, it's really easy to do something else for a bit. In fact, most people do something else for a bit and then go back into a training pathway or something like that. So it's a really kind of low risk time period to try something else and go back into medicine if you want to. it was a little bit frustrating at times. I did really feel like the direct impact I was having was very limited. You're only ever able to see one patient at a time. And even with that one patient, I think you often feel like your ability to influence their outcomes is very limited. You're working as part of a big system which has loads of kind of structural limitations. And it's hard to ever do something that wouldn't otherwise happen, or really feel like you're kind of, having a positive impact. But it's pretty fun. And also you develop a lot of useful skills. So you have to learn really fast. You have to kind of work really hard and long hours. You learn to cope in really very stressful situations. You have to kind of develop decision-making skills under uncertainty. So a lot of medicine, a lot of being a junior doctor is making decisions when you have very limited information. But you do have quite quick feedback loops. And you also, so it kind of allows you to kind of like hone those decision-making skills. And I think it also helps you develop judgment of like kind of when to ask for help, how to ask for help, and how to kind of integrate external advice into your understanding of a situation and what decisions you want to make from it. Which again is basically, I mean, I'm sure that's a really useful thing in all roles, but I found it extremely helpful in what I'm doing now, which is like kind of starting a nonprofit and advocacy and that sort of thing. I also found that kind of practicing medicine for a couple of years was really helpful, just like building my confidence of like feeling like, okay, I'm a person who can do a real job in the real world, and do that like fairly competently. And I think it kind of motivated me and made me feel able to take a more risky career move next, which was at the end of F2, the last kind of couple weeks of F2, I joined, or actually I'll talk about kind of what global health careers I was considering first. So throughout kind of F1, F2, I was thinking a lot about like what I wanted to do next. And I was thinking mainly about kind of potential high impact options in global health. I wanted to use a medical background, and I also just think it's really important. So I was thinking about working for global health NGOs. I was thinking about working for kind of early stage effective altruism oriented kind of health startups. I was thinking about maybe doing some kind of research on maybe some neglected diseases, or maybe pandemic preparedness and that sort of thing. Like, yeah, I had no clue really. But in the end, I decided to try nonprofit entrepreneurship. And the reason I decided on that was basically because I had seen someone else do it. One of my friends had started a kind of wheat flour fortification charity, Fortify Health. And she had actually come out from a non-medical undergrad degree. She'd done like, I think French and something, and managed to do a really good job and like did super well, got GiveWell funding and had a massive impact. And I was like, okay, maybe this is like an option, and maybe this is something that's doable. And I also just thought it would be very impactful. I think doing something that wouldn't otherwise be done, having an impact that like wouldn't happen if you weren't doing the thing, is one of the best ways to maximize your impact. And I thought it would be pretty challenging, and that was kind of appealing, be kind of a good way to explore doing something new, figure out what I can do, what I enjoy doing, develop a lot of new skills quite quickly. So the last couple of weeks of F2, I joined the Charity Entrepreneurship Incubation Program, which is a incubator set up specifically to help people start high impact nonprofits. It's a 2-month program, and basically they spend the previous year like researching charity ideas, and then they come up with recommendations, and you join this cohort of people in this incubator, and they help you find a co-founder. They teach you everything you need to know about starting a charity. So everything like, I don't know, planning, fundraising, hiring, cost effectiveness analysis, monitoring and evaluation, like all the things that you might not even know that you need to know. They kind of lay it all out for you, which was super helpful. And then they give you like mentorship for the next couple of years, and they connect you with a community of other people who are starting nonprofits, and they gave us some seed funding as well. So at the end of that, I started LEAP with my co-founder, Jack, who I met during the program. And so I'm going to move on to talk about that now. So this is a picture of Freetown in Sierra Leone. And this is where you can see, this is a place where the kind of invisible effects of lead poisoning are quite prevalent. It's actually not that invisible. You can see the really brightly painted houses. It's a bit of a clue, but yeah. So lead poisoning basically has a wide range of effects that we never really learned about in medical school. So it has negative health impacts. It reduces children's intelligence. It reduces future income, and it also can cause violent crime. I don't know, maybe if you're not clinical yet, you won't know this, but one of the causes of microcytic anemia in the TAILS acronym, anyone know? Yeah, that's like the only time you ever come across lead in medical school is like as part of this tiny little acronym for causes of microcytic anemia. But it actually has massive impacts. It causes anemia, growth stunting, kidney impairment, high blood pressure, cardiovascular disease, mental illness, and behavioral disorders. I think we don't learn about it much because it doesn't affect people in high-income countries very much. But it also is a neurotoxin, and it has an impact on children's developing brains. Even though levels of exposure can reduce cognitive ability, reduce educational attainment. And you can see that like at a population level, that kind of impact can have a huge effect on the number of children with intellectual disability. In some countries, there's a 50% increase in the number of children with intellectual disability just because of lead. And it has other kind of pretty horrible impacts on the brain as well. And because of this impact on children's developing brains, it reduces their earning potential, which has an impact on economies as well. So it's estimated that $1 trillion is lost to the economies of low and middle income countries every year, just because of lead poisoning. And in some countries, that's 6% or more of GDP. So you can see how that could affect kind of development and poverty and all sorts of things beyond health. And then interestingly, there's also this correlation between violent crime and lead exposure. It is known that lead affects executive functioning and impulse control and aggression and personality as well. And there's a lot of kind of correlational evidence that suggests that it has a pretty strong impact on the amount of violent crime in society. And they even think that maybe around 80% of the variance in crime rate in the US has been due to variations in environmental lead. That graph is just like lead in gasoline against violent crime. And you can see that correlation in different countries across different time periods. It's pretty fascinating. Yeah, so it's also a massive scale problem. All of those effects are impacting 1 in 3 to 1 in 2 children in the world, which is pretty crazy and not really something we hear about. It's thought to account for at least 1% of the global burden of disease and 1 million deaths a year. And like I was saying, these huge losses to the economy as well. So that's the problem, but it's kind of irrelevant if there's nothing we can do about it. But fortunately, it seems like there is, and a lot of countries have successfully addressed lead poisoning. Countries like the UK and the US have banned lead in gasoline, they've banned lead in paint, and lead poisoning levels are now really quite low. We still have some kind of legacy sources like old lead paint on walls or old lead pipes. There are probably some in this college actually, but like overall, it's not a major problem in high-income countries like the US and the UK. But in 59% of countries, there's no regulation on some of the most important sources of lead exposure. So lead paint's one of those. And in those countries, blood levels are averaging at the level of lead poisoning. So like the average kid will have like actual lead poisoning causing those impacts that we talked about before. So that's where LEAP and our intervention comes in. So what we do is we advocate for regulation of lead paint in neglected countries that have large and growing burdens of lead poisoning. And in this context, by neglected, we just mean countries where like this problem isn't being addressed and no one else is doing anything about it. And what that involves is kind of 4 main things. So it's like really targeted research to identify countries where there is high levels of lead in paint. And then we do government advocacy, which basically just means trying to tell governments about it and trying to get them to do stuff about it. And then we do industry outreach. So that's trying to convince the manufacturers to remove lead from their paint and helping them do that. And then we do follow-up studies to kind of track our impact and progress. And the reason we focus on lead paint is because it's one of the most well-evidenced sources of lead poisoning in the world. There are a ton, but there hasn't been very good research into the sources, and we don't really know which ones are most important in which countries, but there's pretty convincing evidence that where lead paint is prevalent, it's going to be causing lead poisoning. And that's because when it's in homes and schools, it just forms like little dust and flakes, and then kids have like hand-to-mouth behavior, and they're always just accidentally getting it in their mouth. And so then they get lead poisoning and all those effects that we talked about before. So because we had this idea, this was kind of research by Charity Entrepreneurship and Incubation Program, this idea for this intervention, but we don't want to start a charity that's not going to be more cost effective than like the best other charities out there. And that's basically because if we're going to be doing less good per dollar, then people would be better off donating their money to a better charity, and it would be better if we just kind of, I don't know, supported that charity or something like that. Because there's a finite amount of resource, unfortunately. And so we want to be going to the most effective causes possible, and we don't want to be diverting funds away from something better. So we drew up like a cost effectiveness model and tried to estimate the impact we could have per dollar. So we look at all the benefits, so the benefits to health, the benefits to income, and then we look at the costs. So the costs to our organization, so how much like, you know, our salaries and running costs and research costs and that sort of thing, and also the cost to governments of implementing the regulation, because that's also kind of relevant. And we estimate that the cost effectiveness of this intervention in Malawi, which is the first country that we work in, is around $14 per DALY averted. I don't know if you guys are familiar with DALYs, but it's basically a measure of disease burden. A DALY is like a year of healthy life lost. So that's saying that for $14, we can bring about an additional year of healthy life, which is really very good. It seems like a great deal. And it's kind of comparable or potentially better than some of the most cost-effective charities out there. But obviously it's quite uncertain because it's early days and we don't know exactly how we're going to bring about that impact, or if we will do so successfully. But we estimate just from like working in Malawi alone, we can eliminate lead exposure for around 200,000 children and save around $180 million in lost earnings. So it's looking pretty promising. And we decided kind of based on these sorts of estimates that this was worth a try. Yeah, so I will now talk about what we actually do and like, yeah, what this actually involves. So we started a year and a half ago. So a year and a half ago, the first thing we did was we were like, this seems like a good intervention, but where should we do it? So we made a big spreadsheet of all the countries in the world. You don't need to read all of this. And we looked at factors like how neglected the country is. Are there other people working on this? Do they already have lead paint regulation in place that's being enforced? What's the size of the lead burden? How many children are there in those countries? What's the estimates of the health costs and the economic costs? And then also, how likely are we to be successful in those countries? Do they have accessible governments that might be willing to talk to us and might be willing to implement these policies based on kind of new evidence and that sort of thing? So we looked at all of that for all of the countries, and we thought Malawi seemed like a pretty good bet as a first try. So then so we started in September, and then in October we went to Malawi. And it turns out like paint advertisements are just absolutely everywhere. I don't know if anyone else has kind of traveled around this part of Africa, or in fact, it even seems to be the case in West Africa as well, but they're just, yeah, there's just a whole lot of paint advertisements. And I don't know if it's just because we were like looking for them, but I don't know, you tell me, like it's just everywhere. And the first thing we had to do was see if we would be able to get in contact with the people who we need to get in contact with. So this is like the first part of advocacy, really, is like making contacts with the people who will be able to bring about the change that we're hoping for. It was surprisingly easy. We've just asked everyone we knew if they had any relevant contacts. So I asked like one of my friends who had done their elective in Malawi if they had any contacts, and they put me in contact with a nurse who they'd worked with. And they put me in contact with their friend who's a health policy advisor. So we got advice from him, and then they put me in contact with the director of policy at the Ministry of Health. I asked my friend who's a YouTuber if he could do an Instagram story. And so some people reached out and they got us in contact with Ministry of Health and the Bureau of Standards, and sent some cold emails to people who'd done research previously on lead exposure in Malawi and made some contacts through that as well. And I think it seems kind of ad hoc, but apparently this is quite standard for like kind of how you make contacts. You just, ask people and you get there. So that was a pretty good start. But the next thing we had to do was figure out whether or not lead paint was actually a problem in Malawi. If it wasn't, then we would be wasting our time there. So what we did was we collaborated with the University of Malawi, and we went around to all of the paint shops in the 2 big cities, in fact, the three biggest cities, and we bought every brand of paint in 3 colors from each brand. And then we brought it back to the back bedroom. This is actually my bedroom, which is kind of sad because it was then covered in lead paint, of our Airbnb in Malawi. And we dried the paint samples, and then we packaged them up and sent them to a lab in the US so they could analyze them for lead content. And surprisingly enough, like most countries have 0 data about whether or not there's lead in paint already. Industry is not transparent. There's no labeling. No one knows at all. So we did that, and that's this picture of all the paints that I proudly collected. And then we found out that most of the paints did have really high levels of lead. And we found out that the biggest brand had the highest levels, which was kind of concerning. And we also found that it was mainly the colored paints, which told us that probably manufacturers are putting paint in the pigments. So that kind of confirmed for us, like, yes, this is probably an important source of exposure in that country. So the next step was actually doing the advocacy, which I never really knew what advocacy meant until I started trying to do it. And basically it just means like trying to get people to do things. So we presented the results to the kind of regulatory authorities and the health ministries, like the Malawi Bureau of Standards. Actually, I guess you guys aren't clinical. Well, some of you are, but you do this thing in clinical school called CCS, which is like communication skills, and you learn like kind of how to have conversations in productive ways. And I genuinely use some of those formats for these meetings because it's really quite helpful. So we showed these results to the Bureau of Standards, and they were like, oh, okay, they actually had thought that lead in paint was like a completely outdated technology that no one used anymore and that it wouldn't be a problem in the country. But then we showed them the data and they were like, okay, right, yes, we will start regulating this, which was really great. So they're going to start monitoring the lead content of paint themselves and enforcing a lead paint standard so that manufacturers will have to phase out lead in paint and children won't be poisoned anymore. So that's exactly what we were hoping for. And they agreed to that just within like 3 months of us kind of starting work on this problem. And yeah, so since then, that was like this time last year. Since then, we've started doing similar kind of work in 5, actually it's more like 6 other countries now. Basically kind of making partnerships with NGOs and governments and doctors and researchers and doing this research and bringing it to governments and trying to get them to implement policies based on it. So a lot of our work is these kind of country trips that I described, like Malawi, but then also there's a lot of just kind of sending emails and having Zoom meetings and writing kind of summaries of information and research reports and advocacy materials and that sort of thing. And I realized I was feeling today like, oh my goodness, we're working in so many countries. I feel like I don't have everything like in my head, like what is going on, like all the tasks that I have to do. And I was like, oh, this is exactly how I used to feel on the ward. Like I literally like, you know, when you can't, well, you won't know yet, but when you just like can't even remember what your patients need and what you're supposed to be doing for all of them. And then I realized I actually structure my to-do list in exactly the same way that I used to on the ward, except instead of like bed numbers and patient initials, I have countries. And then this is my to-do list today. It's a bit overwhelming. But yeah, so we've got just tons going on. A lot of it is just like talking to our partners, getting the research done, having meetings with governments, and some kind of operational and fundraising stuff on the side as well. These are a few pictures of some of our partners. So there on the left, we have our partners in Madagascar. That's the Ministry of Environment, and they've got their paints drying in the background. We couldn't go there to help because of COVID at the time. We couldn't go to Madagascar. And then on the right, we have my colleague Claire in Liberia with the Liberia Environmental Protection Agency. And I think the probably paint in the background is lead paint, but that's okay. And then these are the guys in Liberia. These are some students who are helping us get the paint drying so we can send it for sampling. And on the right, I'm with our partners in Pakistan, some public health doctors who are working with us on the research and helping us kind of get started on advocacy with connections to government. Yeah, and then that's basically what we're up to, and we're going to keep going with that. So over the next year, we'll be working in Malawi to kind of keep going, helping to support compliance and enforcement of this new policy. Going to be doing advocacy in Zimbabwe and Pakistan as well. Hopefully we'll be working with industry in Madagascar and Liberia, where regulations should be coming in like the next month or so, we hope. And then we'll be kind of giving technical support to the paint manufacturers to help them actually comply with regulation. We're hoping to run some paint studies in the next few months in 4 more countries, Sierra Leone, Bolivia, and Niger and Angola. And we also want to start looking at some other sources of lead exposure. Spices are a source that seem really interesting and possibly pretty big in countries that use a lot of spices. Yeah, so hopefully through all of that, we'll be able to reduce lead poisoning in probably like 1.5 to 2 million children over the next few years. Yeah, so I'm down to answer any questions at all about kind of, yeah, any part of that. So let me know.
Yeah, thanks so much. Yeah, that was super interesting. I'm sure you'll all agree. If you guys have any questions, please fire away now or have a few minutes to think about them. We have some like pre-submitted questions, so I'll just run through a couple of those, if that's okay first. Yeah. And then, yeah, but feel free to just pitch in with hands up or just shout, whatever. So the first question I wanted to ask was about the transition away from clinical practice. Was that kind of well received by those around you, and you know, the kind of more kind of mental, emotional side of that? Because that's like, you know, on paper it seems like all the skills were directly translatable, which is amazing. But kind of, how did you feel kind of about that?
Yeah, it was tricky. I think it was quite a scary thing to do. Like when I was initially thinking about it, but when I framed it as like, I'm going to try something else for a year or two and see how it goes, I've always got this as a backup option. Yeah. And I also was planning to do a few locum shifts, and I have done a few locum shifts. So that kind of didn't make me feel like I was like completely transitioning away. And also I have still felt like I'm doing medicine in a way. Like, I think like pure clinical practice isn't the only type of medicine. And when I talk to other doctors, and especially kind of like more senior doctors, they see this as part of like a doctor's work in a way, which helps. I think when you can maintain that identity, it makes it a lot less scary, because once you've been through 6 years of medical school and like 2 years of being a doctor, and then you're suddenly thinking, oh, am I still going to be a doctor? Like, that's really scary, but I don't really see it like that. And I think that helps.
Yeah, that's interesting about like, as you get more senior, you kind of expect to do this kind of thing anyway. You're expected to branch out in your own career anyway, and you kind of got a head start almost, you know? You can go back to doing the clinical whenever you want, if you want to.
Exactly.
Yeah, and the identity thing about being a doctor itself, I think that's something that a lot of us not care about necessarily, but like are drawn to medicine because being a doctor is a thing, you know. It's kind of presented as a thing to kids and so on. But it's nice to hear that you retain that kind of identity.
Yeah, and I work with a lot of people who still like see me as a doctor. Like I work with like some of our partners are doctors, and they see me as kind of a doctor working with them in a medical capacity, and that's really nice as well.
Yeah. No, fantastic. Any other kind of questions about that kind of field, or
I was going to say, how do you think you
I think I would find it, I think, a bit less fulfilling and a little bit frustrating, feeling like, because I still sometimes think, oh, I should do a couple of locum shifts every now and again. But I'm like, oh, if I could just spend a bit more time on this, like the potential for impact is just a lot more. So I think I would do it if I saw it as like instrumentally valuable to allow me to have more impact in this other kind of field of health policy advocacy. And I think it's plausible that it could. But I think I'd find it, pretty frustrating to just be seeing one patient at a time when there's like such larger scale things that I could be having an impact on, if that makes any sense. Although you do really feel the direct impact when you're practicing medicine. Like you feel like, oh, I'm helping this person in front of me, and that's quite nice. But it's when you really think about it, like, oh, if I wasn't here, you know, it wouldn't really make any difference to this patient's outcome. And that's when I feel a little bit frustrated sometimes doing clinical practice.
I mean, like when you just mentioned there, like 1.5 to 2 million children protected like, as a result of your work in the next few years. That's a ridiculous number to try and like get your head around as a person, as a entrepreneur or whatever. So, but yeah, as you said, like in clinical practice, you can see the impact directly in front of you.
Yeah.
Do you have any kind of tricks or like how do you kind of like keep yourself motivated when that number is so like large and abstract?
Yeah, it's definitely like, I don't even think it's like psychologically conceivable to like if I felt like I was like reducing lead exposure for 10 children, it probably feels just as good as 1.5 to 2 million, just because you can't like scale your perception of impact like that. But yeah, so I kind of acknowledge that, and I just kind of sometimes try to motivate myself more based on like the calculations than like the feeling.
Yeah.
Yeah, but it is nice. Like, I think it's nice when I'm interacting with people in our work, like our partners, who really feel the impact of the work, and they're like really feel like, you know, they're protecting their children and their community, and that helps me feel that as well, I think.
Yeah. Kind of like reducing it down to like a very small scale.
Yeah.
Seeing that and extrapolating it.
Exactly.
Yeah. No, brilliant. Anything else? Yeah. Sure.
So for example, with like the commitment in Malawi, the government commitment in Malawi, how confident are you that it will actually be followed through? Because a lot of these countries, like law enforcement is quite weak, and corruption is pervasive. So how confident are you?
Yeah, so not super confident, which is why like our work is not done there at all. In fact, I might be going in a couple of weeks to meet with the Bureau of Standards and see how it's going. One of the limiting factors, so it's a surprisingly easy regulation to enforce. In a lot of these countries, there's only a few paint manufacturers. Like in Malawi, there's only like 4 or 5 local manufacturers, and they already do sampling audits like twice a year. So they have the samples, they just need to test them for lead and then follow up on it. But they have other limitations like lab capacity. Like at the moment, their machine for analyzing lead content is broken. So hopefully we're gonna sort that out by helping them send their samples abroad for a little bit. But this type of problem will happen with enforcement everywhere. And so, yeah, it's not just getting the regulation through, it's also continuing to work with them with enforcement, and then also working on the industry side. So we've got relationships now with all the manufacturers there, and we can make it as easy as we can for them to switch out their lead ingredients. But yeah, it's not simple, for sure. Yeah.
I had a question about like the culture in this kind of like field, basically. So like you said, your model was kind of more cost effective than other charities, which is why it makes sense for you to come into existence, basically. What happens to those other charities, you know, that have been, so was there a lead exposure elimination program that you kind of like beat, or like, you know, that you kind of like were more cost effective than? So how does it work in terms of like, do those kind of other entrepreneurs kind of like get involved in your team, or does it kind of grow, or is it quite like competitive in a strange way, I guess?
Yeah, I think so. There aren't really many lead orgs, so there's not like a lot of competition there. And with the ones that do exist, we're fairly collaborative. Like we have meetings and every now and then, and kind of figure out what everyone's doing and where the gaps are. I don't really think there's much of a competitive vibe. Maybe with some kind of access to funding, but sometimes I wish there was more kind of competitiveness on the basis of impact and cost effectiveness, but a lot of organizations aren't really thinking about that. Like if we really were competing based on our cost effectiveness analysis, then there'd probably be a lot less charities in the world. But yeah.
Yeah, fair enough. And the charity entrepreneurship program in general, that sounds like something I was very excited when I first heard about it anyway, but like I feel like as a third year medic, or even as a medical student in general, there's not massive amounts I can do necessarily. Were you kind of thinking about this whilst at medical school, and what kinds of things do you think we can do?
Yeah, so I was thinking about this kind of thing. I don't think I'd really considered like non-profit entrepreneurship as an option, but I was kind of thinking about like, how can I have an impact with my career? And I think that's why I got involved in like the effective altruism scene, because I wanted to kind of keep learning and thinking about these ideas and help me kind of figure out what I was going to do longer term. So I definitely recommend like getting involved in some kind of community that will help you think about like less traditional career paths and like impactful stuff that you can do, like HiMed. And do you guys have a fellowship coming up? That sounds really cool. I would have loved to do the fellowship. Yeah.
We're talking about that at the end.
Okay, cool.
Yeah. Nice. Yeah. Okay, cool. Anyone else have any general questions about?
When talking to people from the other countries, how easy is it to persuade them to make a change? Doing your basically pointing out fundamentally wrong what they're doing, something, and it's usually totally, I guess, policymakers who don't really like aftercare,
Mm.
or maybe they are really receptive and you just have to.
Yeah, so I think that's one of the advantages of the lead thing being so neglected, is that people really haven't thought about it before. Like if we were coming in being like, oh guys, you really need to do something about malaria, they'll be like, yeah, we know, thanks. But with this, it's like, oh, okay, yeah, we didn't know that. And you're right, there is actually a solution here that's not that difficult to implement. So people have been pretty receptive so far. And I think dealing with industry, it's a bit difficult because like we don't want them to feel like the bad guys, even though they kind of are the bad guys. But a lot of the time they don't really know the impacts of the lead that they're putting in their paint that's poisoning the kids. So again, we try and frame it like, oh, I know you didn't know this, but it turns out this is a really bad thing. Like, how can we figure it out together, sort of thing. Yeah.
Yeah, there's a question.
How do you come across that exposure?
Yeah, I think when I first came across it, I was reading, there's like a website kind of organization called GiveWell, that's like a charity evaluator. I think they had a page on like kind of health policy areas that were maybe interesting and impactful. So I think I first heard about it then. And then the Charity of Entrepreneurship had researched this. And so they'd kind of put together a kind of whole proposal for this charity idea. And so I read through their research and found out a lot more through there.
Yeah. Sounds good. I mean, what kind of other kind of health policy areas do you think are up and coming or particularly under research or neglected at the moment that new charities might enter?
Yeah, so I think there are a few that actually Charity Entrepreneurship are recommending this year. I might get this wrong, but I think one of them is to do with improving the quality of like international aid, kind of advocating to make that more effective. Maybe something to do with road traffic safety, which is like a surprisingly neglected cause of a lot of problems. Air pollution is a really interesting one. That there's probably a lot of space for work and in reducing kind of air pollution in a lot of low and middle income countries. And micronutrient fortification, that's kind of can be a policy thing. Basically like getting governments to put micronutrients like iron into flour, so to reduce anemia levels across a population.
Yeah.
But yeah, there are probably just like tons that no one's even thought of and that people should start thinking more about and researching. Yeah.
I kind of related to that, I guess, like this was a question that came in from the floor. I don't know if the person that submitted this is still here, but so why do you believe that charitable organizations set up by individuals like yourselves are needed to fulfill these roles and like tackle these areas rather than government organizations or like more general global aid by governments?
Yeah, I mean, I wish that it weren't. I think like, yeah, ideally governments would be sorting out the health of their populations. But that's not how it's happening always. And I think if there's a gap that no one's filling, it doesn't make sense to be like, oh, but someone else should be doing this. Like, gotta try and do it. And in collaboration, like it's not like we're actually going to be solving this lead problem. It's going to be governments that are solving it. We're just facilitating it by bringing them the evidence that they need to be able to make the right decisions for their populations.
Yeah, no, fantastic.